Hello, we are Sale Group 3, and we will be presenting a case study for our client, LK. LK is a 9-year-old male referred to us for voice assessment by his school teacher. LK lives in an English-speaking home with a single mother, but his grandmother frequently watches him after school. After facilitating an interview with LK's teacher, we learned that although the client is a very social young boy, he's often absent from class and it's difficult to hear him at times because his voice is hoarse. After speaking to LK's grandma, we learned he takes allergy medicine daily due to his seasonal allergies that often come with a runny nose. Additionally, he was previously diagnosed with ADHD, which he also takes a daily medication for. His grandma noticed his voice problems about 6 months ago and reports his voice sounds breathy, hoarse, quieter, and maybe his pitch is even lower. She noticed that he frequently yells and chants at travel baseball games. When LK was interviewed himself, he reported his pain as 8 out of 10 and mentioned it sometimes feels like there is a bump in his throat. When asked about his vocal fatigue, LK rated his vocal fatigue on a scale out of 10, a 4 in the morning, but he rated it an 8 after a day of school or baseball practice. He also mentioned he has difficulty being heard and feels really tired after trying to talk too much. LK's grandma lets him drink lots of soda and eat food, even if it makes him have chest pain. After interviewing the client, it is clear that he has strong self-efficacy in order to return to his normal activities without pain and fatigue. As far as LK's medical background goes, like previously mentioned, the client sees specialists for seasonal allergies and ADHD, which he's diagnosed with. He passed his most recent hearing screening that was performed 6 months ago, and he also passed an oral mechanism examination during assessment. His grandmother reports client has symptoms of GERD. Therefore, we recommend that LK visits his primary care physicians for further testing. His grandmother completed the Pediatric Voice Handicap Index on LK's behalf. The results indicate that the client shows most difficulty within the physical domain of his voice problem, and his main areas for concern include hoarse voice change throughout the day, and much effort required to speak. Looking at the auditory perceptual Cape V, the results indicated that the two main areas for concern are roughness and breathiness. With that, we will move on to Jaime.
So the acoustic measures here show fundamental frequency, intensity, and MPFR all being below normal limits. This data corresponds with LK's report of having a low pitch, a quiet voice, and minimal range, and LK also reports vocal fatigue. Meanwhile, airflow and MPT being below normal limits, along with PTP and subglottal pressure being above normal limits, indicates that air is escaping when he's trying to speak. If the vocal folds are not properly closing, it will require more effort and subglottal pressure in order to achieve phonation. This is also supported by the visual evidence that was obtained. This shows bilateral lesions on the vocal folds, which prevents full glottal closure of the posterior vocal folds. This results in abnormal symmetry and creates an aperiodic mucosal wave. Conducting an EGG is not necessary for this client, as the video stroboscopy has already provided information about the open-close ratio being high. Since the issue does not appear to be muscular in nature, we would not conduct an EMG either. So for clinical impressions, 9-year-old LK presents with mild to moderate dysphonia that affects his ability to participate in class and extracurricular activities. His voice is characterized by a rough and breathy quality, and he also has difficulty being heard by others in the classroom. Based on the data and client concerns, diagnostic hypotheses include vocal nodules, vocal polyps, or vocal cysts. This is likely a result of things like poor vocal hygiene, for example, dehydration and his frequent yelling and chanting at baseball games. Also, his reflux can play a role, and his seasonal allergies. A differential diagnosis can be completed by stroboscopy that would be administered by an ENT. The confirmed diagnosis is bilateral vocal nodules. The effort required to speak has also caused a secondary condition to arise, that being muscle tension dysphonia. Prognosis for LK is good due to his young age, his motivation to resume his normal activities, and his strong familial support.
So the next step is for LK to participate in intervention, and since he's only 9 years old, it's important to remember that the parents and caregivers will be actively involved throughout the whole intervention process, as well as the teacher who will play a role to evaluate LK's progress that's made in the school setting. So to start an intervention, collaborative goal setting took place with LK, allowing him to feel a sense of control over his intervention process and create some intrinsic motivation to participate in therapy. It was decided that LK will participate in one 60-minute session per week for 15 weeks and will address the following goals. He will rate vocal effort lower than 3 on a 1 to 10 vocal effort scale once in the morning and once at night for 5 out of 7 days. He will demonstrate healthy vocal behaviors as evidenced through patient journal and SLP observation for 5 out of 7 days. And he will produce a resonant voice and conversational speech in 80% of opportunities. In order to decrease LK's vocal effort rating, as stated in goal number 1, we will set small goals to reach throughout intervention. At the beginning, we will focus on lowering his score to less than 7 for 5 out of 7 days, progressing on to lower than 5, and eventually lower than 3. For goal number 2, aim towards increasing healthy vocal behaviors. LK will be measured throughout intervention to achieve healthy vocal behaviors such as no more than 1 can of soda per day, at least 4 cups of water per day, and using a confidential voice. We chose those vocal behaviors through motivational interviewing with LK, remembering that it's easier to change a behavior rather than to extinguish it. And so that's why soda is still going to be a part of LK's everyday life rather than taking it all away from him. For the third goal, to use a resonant voice, we will begin working at the word level, working our way up to sentence level, and eventually reaching a conversational level. In compliance with our goals, we have immediate intervention options for therapy. We have future intervention options that may occur later depending on the outcome of therapy, and we have some options that will not apply to LK's diagnosis and his life. So to achieve our goal of reducing vocal effort, laryngeal massage, chant talk, and easy onset can all be used to try and reduce tension and effort while speaking in order to create a relaxed phonation. These techniques can be easy to implement. For example, a laryngeal massage can be implemented by himself. To achieve our goal of vocal hygiene education, we will use patient education in the areas of hydration and how to reduce phonotraumatic behaviors for LK. By asking the client to track his hydration, he will be held accountable, but also have a sense of control over his voice problem. And in terms of unhealthy behaviors, we will teach him techniques to limit behaviors such as yelling and cheering in excessive amount in order to reduce injury to his vocal folds. In order to create a resonant voice, LK can receive intervention using SOVT techniques and confidential voice therapy in order to work towards resonant voice therapy. Overall, these techniques will work towards a strong and clear voice for LK without sacrificing the health of his vocal folds.
Options that we would consider in the future is vocal nodule removal surgery. It's unlikely that this will occur because it's rarely an option. However, LK and his caretakers need to be informed of this if he struggles to comply with current behavioral intervention. Intervention options we wouldn't recommend at all are Lee Silverman voice treatment, vocal function exercises, and vocal rest. Lee Silverman voice treatment targets hypofunctional behaviors, which is done using hyperfunctional behaviors, which we wouldn't do because it's counterintuitive as our client experiences hyperfunctional behaviors. We wouldn't use vocal function exercises or vocal rest because they're unreasonable to expect our client to follow. They're a little difficult and he wouldn't comply with the necessary components. Examples of how intervention would play out. In the first week, we would introduce him a journal for vocal hygiene. He'd fill it out at least 5 days, and he'd get to put a sticker on every day he fulfills his expectations. So if he doesn't drink a soda or he only has 1 soda, he can put a sticker on it, and it will remark on his vocal usage on a normal day and help him identify his phonotraumatic behaviors for him to use that educational purpose. We'll also practice replacement strategies to reduce vocal injury, which provides him with a scenario that he needs to justify which voice and type of voice he would use. Later sessions, we would address the reducing vocal effort and producing a resonant voice. In our earlier weeks, we would introduce things like laryngeal massage, straw phonation, chant talk, and easy onset. These are all addressed to reduce vocal effort, and they can be addressed over the span of numerous weeks to help the client effectively learn and attain this skill. Each exercise will also be addressed randomly throughout the session, kind of intermittently through the activities to help retain the skill. In addition to his vocal hygiene journal, we would add a vocal effort scale as evidenced in this slide. The 1 is easy voice, 10 is hard voice, and he has to fill it out once in the morning and once at night to indicate how he feels when he wakes up and then after a day of speaking. Again, his motivation is going to be through interests like baseball and video games, and he might even practice his easy voice with baseball chants since it's applicable to his everyday life. In addition, we would introduce a visual support, which is like something, as an example here, is the light, traffic light, and the red indicates a high vocal effort, green indicates a low vocal effort. And it's just a visual for him. He can rate himself. Clinicians can remind him that he's using his high voice, so he's red. It's just an easy way for him to see and to reduce his vocal effort if necessary. He'll also be introduced to confidential voice therapy, and that's going to be intermixed with the other intervention techniques we talked about of laryngeal massage, chant talk, easy onset, straw phonation. Lastly, after the confidential voice therapy is introduced, that's only used for a couple weeks, and we would gradually move from that to resonant voice therapy. Resonant voice therapy would be done with delayed intermittent feedback to help him learn the skill efficiently and so that he continues using his resonant voice throughout his everyday activities.
So after intervention with LK, his prognosis was very good, which is proven in his post-intervention results. We see in his KBV results that all his levels have decreased and go into more normal and comfortable levels. Then in his handicap index, LK reported improvement showing that the intervention methods during therapy were successful. In his acoustic measures, all of the data post-intervention has now changed to be within normal limits because LK's nodules are no longer present. His vocal folds are able to close completely, allowing mean airflow to now become within normal limits. Due to this change, now LK's subglottal pressure is within normal limits, and since air can no longer escape through his vocal folds. Here we see a picture of LK's stroboscopy showing his bilateral nodules on the left pre-intervention and then post-intervention on the right once they're no longer present. Because LK responded so well to therapy, surgery is not recommended for LK. LK reported no pain while speaking to others and reduced effort to speak, which were two things that were present pre-intervention. He also now understands the importance of vocal hygiene, like not drinking as much soda, not yelling as much when he goes to baseball games, and other things like that. SOVT was very helpful for him because it allowed him to use a resonant voice. Pre-therapy, LK was diagnosed with bilateral vocal nodules due to hyperfunction vocal use. After intervention methods that focused on techniques to address hyperfunctional vocal behaviors like SOVT exercises, laryngeal massage, and confidential voice therapy, LK felt a huge improvement in his voice. He became less breathy, required less effort to speak, and experienced almost no pain. Because of LK's motivation to participate in social events like baseball, his prognosis is very good. We recommend that he continue to keep a journal for his vocal hygiene and keep practicing all the techniques learned in therapy. We also recommend he continue to see his allergist to monitor his allergies and the medication he takes to control it. We also have asked LK's grandma and parents to keep continuing all their support for LK and hold him accountable for all of these things just to ensure that his vocal nodules don't return. And that's our presentation.